Hi everybody, this is Dr. Ihab Abdurrahman, consultant of acute care medicine at Soba University Hospital, professor of medicine, University of Khartoum, dean of Sama Institute of Health. We are still doing the session about difficulty in breathing. This is part of basic emergency care course. As we mentioned that after you do the ABCD primary survey and you fix the life-threatening condition, you try to recognize sign of difficulty in breathing and list the high-risk causes of difficulty in breathing, perform critical skills for high-risk causes of difficulty in breathing. We have discussed the symptoms, sample symptom, sign, allergy, medication, past medical history, plus last oral intake and events surrounding, and then we discuss the physical finding you're going to see in secondary survey. Now we will highlight some management of important causes of difficulty in breathing. If you suspect airway inflammation or if there is feature of burn, try to keep your patient calm, give him oxygen, and if patient is alert without other injury, you can sit him up and make him comfortable. And if there is with the burn and inflammation, there is a stridor and airway edema, consider definitive airway management by intubation or by tracheostomy, but definitely you need to make sure the resources are available for management, which mean the materials plus skillful personnel to do it. Those with choking, if there is a foreign body inside the mouth, you can remove it. But those who arrest, then you do CPR. But if some showing feature of choking, you can use the Heimlich maneuver by doing abdominal thrust or chest thrust. I'm going to do a link for one of the video to show how you can do this maneuver in adult and in children. Those with allergic reaction, try to remove them from, if it's gas, you move them. If it is infusion or medication, you have to stop that. Remove the exposure to allergen, and when they have stridor or feature of anaphylaxis, you use adrenaline intramuscularly without any delay and give oxygen. Plus, if they are hypotensive, they need IV fluid. Those with asthma, you give oxygen and you give salbutamol inhaler and nebulizer. And those with difficulty in breathing and fever, if you are suspecting pneumonia and sepsis, they need fluid resuscitation, and if they are hypoxic, they need oxygen. And early use of oxygen is early use of antibiotic is important to control sepsis. Those with suspected heart attack and tachypnea, if the tachypnea due to pulmonary edema, you're gonna give oxygen, you're gonna use Lasix to reduce the pulmonary edema. At the same time, you wanna manage the heart attack by giving aspirin, nitroglycerin, and other appropriate medication. Those with anemia, if anemia leading to pulmonary edema, you give Lasix and arrange for transfusion. Those with diabetic ketoacidosis, you have to resuscitate them, you have to give IV fluid, you need to manage the electrolyte disturbance and insulin as appropriate, and if there is concomitant infection, you treat that. Those with opioid overdose, you try to stop further exposure to opioid. You can use a bag valve mask ventilation, and sometimes they might need intubation. If naloxone is available, you try to give that. Make sure that you have to monitor them because the half-life of naloxone is shorter than many of the opioids, so you might need to give repeated doses of this antidote. Suspected large pleural effusion or hemothorax, oxygenate, try to remove the fluid by drainage and put chest tube. And here also you need someone with competency to place the tube safely. Those with trauma and tension pneumothorax or cardiac tamponade, give oxygen. For tamponade, you can give IV fluid till you get someone with appropriate resources to drain the tamponade. For pneumothorax, you can do needle thoracostomy and then you have to place chest tube. Those with sucking chest wound with put three-side occlusive dressing and prepare for transfer to appropriate geographical area. Patient with sickle cell disease and acute chest syndrome, they need oxygen, they need fluid, and if there is infection also they need antibiotic. After you manage the ABCD and after you do the secondary survey and try to figure out other causes and you start the management, make sure you continue monitoring your patient. Inhaled medication like salbutamol lasts for 3 hours. Severe allergic reaction can return when adrenaline wear off. Naloxone, it works for 1 hour, so you might need to repeat the dose. Following submersion injury, a person may develop breathing problem later on. Never leave a patient who might need definitive airway placement unmonitored. So he has to be attended by someone who can recognize the symptom and who can call for help, and you have to get appropriate equipment available by the bedside. Make transfer management as early as possible for any patient who may require assisted ventilation. In summary, while after you do the primary and secondary survey, just this summarize, choking and coughing can point to foreign body. Stridor can happen with anaphylaxis and airway inflammation. Facial swelling can happen due to burn and exposure to some medication and allergen. Drooling indicate blockage of to swallowing. Soot in the mouth and nose can indicate smoke inhalation. Chest wall trauma can happen following rib fracture or if there is a flail chest or pneumothorax. Decreased breath sounds in one side can point to hemothorax or pneumothorax. Hyperresonance go with pneumothorax. Dullness go with hemothorax. Pulmonary edema and heart failure manifest by crackles and hypoxia. Wheezes can happen in allergy, in COPD and asthma. And those with DKA can have tachypnea and cosmal breathing, plus they can be dehydrated. Pericardial tamponade can present with shock, plus engorgement of the neck vein. Those with opioid overdose can have altered mental state, plus irregularity in the pupillary size. Thank you very much. Please make sure to look at the video in the comment below so you can know how to do some of the important emergency maneuver. Thank you.